Arbeck. I'm the director of the Breast Center at LMU University Hospital in Munich, Germany, and the chair of the ESMO Early Breast Cancer Faculty. It's a pleasure for me to look a little bit back into the year 2025 and see what was really clinically relevant in early breast cancer. My disclosures. So I think I picked out 3 topics because I thought they are really game changers. One is local regional therapy. The other is hormone receptor positive, HER2 negative early breast cancer, where we saw a new class of drugs enter the curative setting, and then the HER2 positive space. Let's start with local regional therapy. There were, I think, 2 changes in the way we treat the axilla. One is something that we've already incorporated, but now we sort of see that it's actually safe to do so. That was the Axana study presented at San Antonio 2025 by Thorsten Kühn and colleagues, where they looked at patients that had node-positive disease before neoadjuvant therapy and then converted due to neoadjuvant chemotherapy into clinically node-negative, and they randomized axillary node dissection versus sentinel biopsy or targeted axillary dissection, whatever the clinicians wanted to do. And as you can see here, there is absolutely no difference in long-term local regional outcome. Both methods, axillary dissection as well as the sort of more targeted version, are perfectly safe to do. Interestingly, they also showed that for the 3-year axillary recurrence-free survival, sentinel node and targeted axillary dissection, which is when you mark a node and then take it out afterwards, are actually very similar. But I think the data is too not mature enough to say whether we can actually just use a sentinel procedure and not have to clip or mark the nodes before, because there was an imbalance in the local regional radiotherapy between these groups, and there was not a randomized comparison. The other point where I think we also already incorporated that, and with the data from San Antonio 2025, I think it's now a very solid database, is the omission of sentinel lymph node dissection in low-risk hormone receptor positive, HER2 negative early breast cancer. We now have, with the Dutch study that was presented at San Antonio, 3 trials, the BORG study, the SOUND study, and the INSEMA study, showing that outcome is very similar between sentinel procedure and no sentinel procedure in patients that are 50 years or older, have a small tumor up to 2 centimeters, grade 1 or 2, and hormone receptor positive, HER2 negative. So I think for these patients we can implement this immediately, and we've done so at our center already following Toralf Reimer's presentation at San Antonio 2 years ago of the INSEMA trial. Let's go to the medical therapy, systemic therapy. I think one of the highlights of the ESMO 2025 was the presentation of Steve Johnston, the Monarch E study, with the first overall survival data. Monarch E had these 2 cohorts based on high clinical risk or intermediate clinical risk, 1 to 3 lymph nodes, and then high Ki67, and tested abemaciclib for 2 years versus just endocrine therapy as an adjuvant strategy. And we saw a carryover effect with a strengthening of the IDFS benefit in yearly rates, now about 6% at the 7-year mark, benefit for patients treated with 2 years of abemaciclib in this high-risk node-positive population. And the benefit increases after the patients have finished their therapy. But I think the highlight was that there's now also an overall survival benefit of about 2% at 7 years, which is statistically significant according to the study criteria, and shows that this is a long-lasting effect if you give 2 years of abemaciclib as a CDK4/6 inhibitor in this high-risk node-positive population. This is the first time we saw an overall survival benefit for an adjuvant CDK4/6 inhibitor. Obviously, at ESMO, we also saw the 5-year data of the NATALY study for ribociclib, which shows consistent results in IDFS and distant disease-free survival, but the overall survival data is not yet mature, as this study also covers a slightly lower risk population. And then at San Antonio 2025, we saw the lidERA study, which was the first study reporting out for an oral SERD in the curative setting. The eligibility criteria is somewhat overlapping with the CDK4/6 inhibitor criteria, high risk node negative or node positive disease, and patients are randomized to 5 years of giredestrant versus standard of care endocrine therapy. And we saw a significant benefit in IDFS. Curves start to diverge early at the 1 year mark already, and there is about a 3% difference at 3 years with a hazard ratio of 0.70. Interestingly, the type of endocrine therapy that giredestrant was compared to really didn't matter that much. Data very similar also for distant recurrence-free survival, so there seems to be a long-lasting effect here that will actually lead to better outcomes for those patients treated up front with an oral SERD with a very similar hazard ratio. Overall survival data obviously are not yet mature. And regarding safety, as this is a new drug of class of drug entering the early breast cancer space, we see that safety is very similar to the standard endocrine therapies. Although we had expected the musculoskeletal disorders to be a bit better, we see they're numerically a bit better, but not really strikingly so. The bradycardia that was also reported with giredestrant is clinically not relevant. For patients that do not have a chance to get the oral SERD up front, there's numerous studies out there looking at oral SERD, so patients still have a chance this year to get an oral SERD. In the ELEGANT study, for example, with elacestrant, there's also a preoperative study called ERICA by the ABCSG, WSG, and there's the CAMBIA program for camizestrant. So lots of chances for patients around the globe to still have a an oral SERD before actual registration of giredestrant. The other highlights I think we saw were the ESMO presidential lectures at ESMO 2025 in the HER2 positive space, where we saw 2 studies looking at the neoadjuvant or the post-neoadjuvant component. And here the ESMO guidelines clearly state in HER2 positive early breast cancer 2 centimeters or larger or node positive that we should go for neoadjuvant chemotherapy and then do a PCR status-based individualization in the post-neoadjuvant space, with TDM1 being our standard of care for residual invasive disease. The 2 studies we saw, one of them was the neoadjuvant Destiny Breast 11, which I personally had the honor of presenting at ESMO last year. And the study looked at 3 arms, 2 of them with TDXD, one sequential arm TDXD followed by paclitaxel dual blockade THP, the other 8 cycles of TDXD monotherapy, and the standard of care that those arms were compared to was dose-dense AC followed by THP. The monotherapy arm with TDXD was closed early due to multifactorial reasons, and the other thing that is of importance is that the post-neoadjuvant therapy was recommended but not mandated which type, and the patients in this study were mostly high-risk node negative, so large tumors and node negative, or the majority was node positive. About 90% in this study were node positive patients. Primary endpoint was PCR, and you can see here that the study met its primary endpoint. TDXD THP was significantly better than standard of care dose-dense AC followed by THP, and this advantage was present in HR positive and HR negative disease, with in the HR negative space 4 out of 5 patients having a PCR. The early glimpse at EFS showed that there was already a difference with a favorable hazard ratio for T-DXd THP, although the data are not mature, then we still have to wait for more events coming here. The safety was, I would say, surprisingly good. We had much less ILD events than the metastatic setting, about half than we are used to from T-DXd in the metastatic setting, because this is an untreated patient collective. And also there was hardly any cardiac toxicity in the T-DXd THP arm, and overall the safety profile was more favorable for T-DXd THP than for dose dense AC followed by THP. The other study presented right afterwards by Dr. Geyer from the NSABP on behalf of the investigators, Dr. Leubel, GBG, was the senior author, was the DESTINY-Breast05 study, which looked at the post-neoadjuvant setting in patients with residual disease, also a high-risk situation here, inoperable and any kind of non-PCR, or operable and node-positive non-PCR. And patients were randomized to T-DXd versus TDM1, and this study met its primary endpoint. It didn't just meet it, it really showed a substantial improvement with a hazard ratio of 0.47 at 3 years, favoring T-DXd over TDM1. And also the secondary endpoints are already moving in the right direction, distant relapse-free survival, as well as the brain metastasis-free survival, which is numerically less brain mets in the T-DXd arm, although this data still has to mature. The side effects are a bit different. T-DXd has more chemotherapy-associated side effects, and the side effects of interest, like ILD, is more like in the metastatic setting, with about more than 10% ILD cases. Unfortunately, also 2 deaths, so proactive management, like in the metastatic setting, is very important also in the post-neoadjuvant setting. And with that, I would just like to summarize what have we seen in 2025. I think local regional therapy, Sentinel, is safe in the context of neoadjuvant chemotherapy, and the omission of a Sentinel node procedure is safe in the low-risk hormone receptor-positive HER2-negative space. I think this is something that we can implement immediately into clinical practice. The hormone receptor-positive space, Monarchie showed the first overall survival data for an adjuvant CDK4/6 inhibitor, in this case abemaciclib. The NATALY study, the data are maturing as well for ribociclib, but overall survival data are not mature yet. And the lidERA study showed for the first time that an oral SERD is better than standard endocrine therapy in the adjuvant upfront setting. I think this is very exciting, and there's lots of studies still ongoing, so patients can still be randomized in this setting. And in the HER2 positive space, I think in the post-neoadjuvant setting, T-DXd is substantially better than TDM1. And personally, I think we should implement those data, because these are very high-risk patients, and we started asking for reimbursement on an individual patient basis in patients that qualify for DB05. And in the neoadjuvant setting, T-DXd THP is better regarding PCR than the standard of care. It has a very good safety profile. I think we need the data to mature a little in order to show that this EFS effect is a constant one before we can implement that into clinical practice. And with that, I would just like to close and encourage you all to visit us at the upcoming ESMO Breast, as well as other ESMO meetings throughout the year, to have more recent information. Thank you so much.
Thank you, Nadia, for this exhaustive presentation of the early breast cancer data presented this year at major conferences. I have actually a question on the local regional treatments, possible modification for our clinical practice. Do you think that the sentinel node biopsy can be safely avoided today in low-risk patients, especially taking into account that this could modify the access to adjuvant ribo, for instance, in this type of patients?
Yes, I definitely think so because we've seen now 3 studies showing that the survival, the outcome, also the local regional outcome is very similar between sentinel and no sentinel. So I think it's safe from a patient point of view to omit the sentinel procedure. And with regard to the adjuvant ribo question, I think we're missing very few patients here because that we underestimate the axillary lymph node involvement is maybe about 10%. And the other thing is we're restricting it per guidelines to the luminal A-like small tumors. So here, there was a study in Germany where my colleagues looked at gene expression analysis in this cohort, and they found that the majority, like over 80%, had a low risk gene expression profile. So we're looking at G1 and G2 tumors, small tumors, hormone receptor positive, HER2 negative. So I think it's very safe because here, if the patient had one lymph node, the biology would still be a very favorable one, and the individual benefit from ribociclib would probably not be the 5% that we see in the overall population, but rather lower. And so I think it's a favorable biology, and we should talk to the patient. And if a clinician or a patient feels that they really want that information, they can still do a sentinel. But I think the standard of care should be to avoid it.
How do you think that we might be able, taking also into account the ongoing trial with elacestrant, to use the new SERT into the adjuvant treatment? Because this will leave the metastatic breast cancer patient population with ESR1 mutation without an option to use this new SERT.
Well, I think that the lidera study is very exciting. I might be biased because I'm one of the co-authors, but I think none of us expected to see the curves diverge so early. So I think it is simply the better endocrine therapy, and we should always give the best therapies in the curative setting. There's more studies coming. There is studies also like we're going to do from the WSG study where we look at elacestrant plus ribociclib in the Adaptela study, for example. There's other studies which have the CDK4/6 inhibitor and then randomize patients afterwards after 2 to 5 years. So we're not sure what's the best way to integrate oral SERDs into the early breast cancer space. But I think if we can cure more patients, that has absolute priority. And for patients in the metastatic setting, I mean, we have in the ESMO guidelines that we can re-challenge which drugs if we haven't given them for about a year. And we still don't know whether in the metastatic setting the oral SERDs are even better as like in combination therapies than a single therapy. So I wouldn't worry too much. I think it's great that we have now more options, and I hope that we finish the other oral SERD trials soon in the early breast cancer space.
Thank you. Thank you so much.